Welcome, everybody. Thank you for joining me. I'm saying hello from beautiful Valencia in Spain, and we will dive immediately into predictable aesthetic dentistry, veneers, composite artistry, and digital smile design. Well, we will start with the fundamental, the smile design, because this gives us the fundamental of how we have to do our work later. Okay, then later we will talk about the basic, the adhesion and the composites, and then at the end about the veneers. And I will share with you some very special veneers knowledges that are not so widely known, but are very fundamental to have a very predictable aesthetic outcome. But let's just dive in, okay, the fundamental. Well, in order to make a smile design, digital or not, okay, the digital smile design only makes now everything that we have made beforehand with our hands. We do it now digitally, 3D CAD/CAM. Usually it's done by our dental technician, okay, but not like that. We have to give him all the information that he has to translate into the 3D model, okay? So we decide what to do. So we are the architect of that digital smile, and he designs it on the 3D model, okay? And then we check and counter check and we have to refine everything that he does. And at the end, when we say, now it's good, then he goes and makes it, okay? So what information do we have to make a nice digital smile design? Well, we have to make an analysis, x-rays, model taking, okay, which is nowadays a scanning, okay? So in the x-rays, we already see how everything is from inside, okay? If we see things like these, that's, of course, something that has to be addressed before we do any smile design on this patient, okay? So anything we can see that has to be addressed beforehand has to be done before we do everything. Then, by scanning, we can determine the occlusal line, the frontal teeth, are they under and over the occlusal line? And we also have determined how much we will have to reduce later the enamel in order to get a beautiful smile at the end, okay? Then we have to take pictures. Pictures will give us A, the state of the beginning, B, a source of discussing with the patient what can be done and what is his desire, and getting information from the patient what's his desire, and then also giving him some hints of what could be on top of it, be made better, okay? Now, these pictures have to be taken very professionally so that we have that's the minimum thing that we have to take. So a smile, then a normal position from the side, and then intraoral from the side, from lateral, from the front, from the other lateral, upper and lower. That's really the basic thing, okay? Digital smile design, DSD, the DSD concept, has other pictures from, from different angles that show us also the facial incorporation into of our smile design into the face later, okay? So then we have to make sure periodontally and gingivally everything is all right, okay? So this patient has to be treated beforehand before we really do something nicely on him, okay? So then we also do previous steps before we really do the smile design. So we do orthodontics, because now if the teeth are really all over the place, it makes much more sense to put them into the correct position and then make the smile design out of that position. We whiten, we eliminate the gummy smile, we do endodontic or re-endodontic treatments, we replace old fillings. Once all that is done, we start our analysis and our design. Okay, so orthodontics, whitening, gummy smiles, we do that with the laser, okay, and re-endodontic treatment with or without ceramic posts and reconstructions, and then we replace old fillings to have a good basis for the new veneers that we want to place, or for the new fillings that we want to do. Okay, then we analyze the smile. The smile analysis, usually we can follow a smile evaluation form that you can download from the internet very easily. So the basic thing is that there are many things we have to keep in mind. Okay, this is not a lecture about smile design analysis. Okay, it's just giving you some hints about what has to be looked at. Okay, a lot of things. Then what do we look at? We look at the tooth and the gingiva at the lips of a person. Okay, the framework of our final work. Then also the smile per se, the face, and then the whole individual. Okay, is it a long face, very tiny, small teeth in the long face, do not look good, and so on. Okay, then basics of the great smile, the gingival criteria, tooth criteria, tooth arrangement in a smile. So if we look at a face, we have to look on several things. First of all, are the teeth in the real midline of the face? Yes or no? Okay. Then, are the canines more or less in the lateral sides of the nose? Okay, when the patient smiles. Okay, this is the basic arrangement of our basic smile. We can make also a face picture and send that to the dental tech that he sees more or less where the canines are, where the midline is, and so on. Okay, then the contrast point of the face. What are these? These are the eyes and the smile per se. Okay, eyes and the smile and the canines. Okay, so the corner of the smile, the canines, and the eyes. How are they related? I will show you later. Okay, now we analyze the smile. We can use programs for that, so digital programs to analyze digitally the smile, or we can analyze by ourselves. Okay, you see here, for example, this eye is way more in than this eye from the midline. Okay, so then where is the incisal edge? Okay, usually from the lower face, we divide the lower face in 3/3, 2/3 from the incisal edge down, and 1/3 from the nose to the incisal edge. Okay? So we see where we have to place our borders so that it looks good. Okay? The long axis symmetry in the eye position, is there symmetry? Yes or no? Okay. Is the dental midline really with the face midline? Yes or no? Should we shift it? Yes or no? Okay. And all these things. Okay. All these things help us to analyze this smile. Also, is the face more or less divided into 1/3, 1/3, 1/3, or no? Is the lower part of the face too small? Then we have to make a vertical dimensional increase here, okay? Then we have to look at the central dominance. So the central incisors are really the dominant ones. So they are the key to a smile. They have to have symmetrical size and shape and be dominant. okay? That will affect the appearance and the placement of the canines and the laterals. So usually the width, so the normal length of a central incisor is between 10 and 12 millimeters. Why between 12 and 12, 10 and 12? Well, because there are large faces and there are smaller faces. So smaller faces, 10, large faces, 12. The ratio, that means the relationship between the length of the central incisor and the width of the central incisor is usually around 80%. That means from the length, if the length is 10 millimeters, then the width is 8 millimeters wide, okay? If it is not like that, if the length is longer than this width, then the tooth looks too long. If the width is 90% of that length, then the tooth looks too wide, okay? Also, we can analyze the golden proportion so that we can see, okay, can we apply this golden proportion in this case, always taking into account in the face where the canines are placed, okay? So there we do the distribution of all these teeth. Well, let's see how eyes and smile are related together, okay? So if a person, this is not a real full smile, but if the person smiles a lot, okay, then we draw a line from the edge of the eyes to the edge of the smile, okay? Edge of the eye to the edge of the smile. Edge of the eye to the edge of the smile. Like this, okay? Like the white line here, okay? So what does this white line tell us? Okay, usually here, because it's not fully smiled, it looks too angled, okay? Usually it's not so angled. But that gives us first the occlusal plane and then the angulation of the canines, okay? How the canines should be angulated. You see here the line from the eyes to the smile, and then following that line, parallel to that line, the angulation of the canines, okay? And the angulation of the canines tells us how we have to angulate all the other teeth, okay? So axial inclination, it's called. The axial inclination is the vertical alignment of the maxillary teeth with regard to the midline. Now, the midline is of course straight, okay? But all the teeth have some inclinations. And the further we go back, the more inclined it is, okay? Good. The mesial inclination is progressively increases from central to the canine. So these inclinations, all these inclinations, they all intersect at the navel, at the belly, okay? All together come towards the belly of the patient. Okay? That is why when one tooth reaches out and is too straight, it looks weird, okay? So we really have to look that all the teeth, also the premolars, the molars, and so on, have an axial inclination. Affected by the gingival shape, contour, and zenith of the teeth, the line draws through the long axis of the teeth. Narrow arch appears more inclined than a wide arch. Okay. Where is the actual inclination here? It's not there. there is no harmony in the inclination, okay? So we have to find a way so that our final veneers or final restorations have that inclination. This is one of the predictable aesthetics that we have. Okay, good. Then the color and other effects on a smile. So the color is not an exactly defined value, but a sensory impression which occurs due to the light reflection of part of the object to the eye, which is translated in the brain. So what does that mean? Okay, that means the color is characterized in three ways: the color tone, intensity, and if it is bright or darker. Okay, so we have green, bright green, and dark green. Okay, we have an intense green and a more washy green. And we have green, and we have blue, and we have red. So that's the tone. Okay, so we have different colors in our teeth. Indeed, we have different colors. So our teeth are not exactly the same. Also not the veneers should be in the same color or tone, okay? We have the clearest in the upper jaw is the central incisor, the second clearest, the lateral incisor, the third clearest it would be the premolar, and the darkest would be the canine, okay? And the color is more bluish in the front and more yellowish in the canine. In the lower jaw, it's different. There we really have clearest, second clearest, third clearest, fourth clearest, and fifth clearest. It's not like in the upper jaw, okay? Effects of color. If we have a darker shade in between two shades, that darker shade looks smaller. If you have a lighter shade, that lighter shade looks bigger than the other two. Okay, we can play with that. If we have a narrower arch and want to expand that arch, we can make lighter colors so they appear to be bigger, these teeth. Okay, so how to play with colors? The full arch may appear narrower if you keep the lateral teeth in a shade darker than the anterior teeth, or if you make them a shade lighter, they appear wider. So how to take the color? One of the tricks is to take the white color of the eye of the patient, okay? Take the color in the afternoon. Why? Because the sun is in a better position to see the real colors of the teeth. Then avoid direct sunlight. Why? Because the reflection of this direct sunlight makes the colors of the teeth look different. Then your light lamp should have about 1,500 lux because it's the best indication. Then the walls of the office and the clothes should have a neutral color that should not be reflected in the teeth. And, you know, this reflection on the teeth change the color of these teeth. Women should be without makeup. And a blue cardboard next to the patient's face increases your sensitivity of your eyes in front of the yellow tones. So you see the yellow tones much better if you have a blue cardboard right next to the face of the patient. If you look at the teeth, okay? Then the 5 seconds rule. The 5 seconds rule is do not look at the teeth more than 5 seconds in a row, because then you don't see anything then. So you look at the tooth, 5 seconds, okay? Then you choose the color and then you look again, not more than 5 seconds. No, it's not the correct color. This, no, that's not the correct color. This, no, that's not the correct color. That's better color. something like that, okay? But not more than 5 seconds in a row. Take the color before you start working. Your eyes are relaxed. The usual thing the most dentists do is they work, they make the impression, they make the preps, the impression, they make the provisionals, and then, oh, the color, okay? And then they go ahead and take the color. But their eyes are tired in that moment, okay? They were so concentrated in doing all other stuff. The eyes do not see correctly in that moment, okay? So start to take the color before you start working. Then the patient should be standing, because if he is inclined in the chair, this gives another impression of the colors. Moisten the teeth of the patient when you take the color. Moisten also the shade guide when you take the color, okay? Take the original color in the central third of the tooth, not the cervical, not the incisal third, okay? And what is really important in a smile design? Well, listen to the patient. Their subjective aesthetic desires should be your guideline. If they like long canines, well, they like long canines. What can we do? Okay. Communication of the treatment options. So that is very important. You can say, okay, listen, what you want to achieve, we can achieve this way, and this way. Now, with composites, with veneers, or with another option like flowable, injectable, direct composite veneers. And it's important, the patient is right. His aesthetic is the correct aesthetic, because he has to see himself every day in the mirror. Not you. You don't have to look in the mirror, the patient in the face every day. Okay? The patient is right, and the patient is right. That's the most important thing. Good. Let's go over to the adhesion and composites, the basic things that we have to understand from there. Adhesion also helps us to understand the veneers adhesion, okay? Good. Let's go. First things first. When I was young, I mean really young, dental student, I mean 1993, so 1993, 33 years ago, okay? There was a difference between adhesion on enamel and adhesion on dentin at that time, 33 years ago. Nowadays, there is no difference. Here's, for example, a publication of 2024, and they do different adhesives with different composites on first enamel and second dentin. Same things, and they compare the adhesion forces to each one of them. And we see here enamel ranges from 15 megapascal, which is the shear bond strength, okay, up to 24 megapascal, okay? So it depends on which adhesive we use and which composite we use. We have between 15 and 24 megapascal on enamel. Let's see how it is in dentin. In dentin, it's between 15 megapascal and 24 megapascal. Wait, that's the same. Yes, it's exactly the same. So nowadays, we can bond to enamel and to dentin in the same way. We get the same results. Can we adhere or bond to dentin? Clearly, yes. Okay. So now a little bit of anatomy. Here is the enamel. That's the dentin. That's the pulp. Here is the cementum. That is dentin. Okay? The cementum, how thick it is? Very thin, microscopically thin. Very thin. Very, very thin, the cementum. Okay, so what happens? What's underneath the cementum? Dentin. Same dentin, as here in the crown, same dentin as in the crown is there in the root. Okay, good. Then what do we have here? Do we have enamel? No. Do we have dentin? Yes. And if there is a recession, then we have cementum, but this cementum is brushed away. So whenever we look on a recession, on a tooth with recession, we don't look at the cementum in that moment. We look at the abraded cementum, and underneath of the cementum is dentin. So we look at dentin. Again, can we adhere to dentin? Yes, we can. Okay, so recessions are okay to adhere, veneers or bonding, whatever, because veneers are cemented with a composite, and the composite can be adhered to dentin. No problem. The problem is, here's the problem. The problem is the two structures is hydrophilic, and the composite and the adhesive or the bonding. When I say adhesive, I mean bonding. If I say bonding, I mean adhesive. Okay. And the composite and the adhesive are both hydrophobic. Okay. That's the problem. That's the only problem. Okay. So, and we have to put them together. And that's why the technology in adhesives or bondings is so sophisticated, so that we can do that. So how long do we have to etch? 15 seconds? Yeah, 15 seconds. The problem is, in dentin, if we increase the etching time, okay, if we etch long, then the penetration into the dentin is deeper and deeper and deeper. And then when we put the adhesive on it or the bonding, we could have some nano leakage, not micro leakage, but nano leakage. And this nano leakage will lead later on to adhesion loss. That means that fillings after a few years just fall off without decay around it or something like that. They just fall off. They don't have the adhesion anymore. They lost it because of the nano leakage. Okay, good. So nano leakage can lead to micro leakage also, and that is bad. Good. So 15 seconds total etch. It's not enough for enamel, and it's too long for dentin. So if we really want to have a completely correct adhesion time on each one, then we have to do 5 to 10 seconds on dentin. Why 5 to 10? Because there is sclerotic dentin, there's tertiary dentin, there's different dentins. Okay, there is virgin dentin and virgin dentin 5, and sclerotic and tertiary dentin 10 seconds. Okay, then the adequate etching time on enamel to really get a good adhesion is 30 seconds. With orthophosphoric acid, 32 to 37%. Good. Then we have to also have in mind always which bonding agent we use, what solvent is in it. The solvent determines on what surface we have to apply it. Do we have to apply it on a wet surface? I mean, moist surface, not wet, moist. Or do we have to apply it on a dry surface, really dry? Well, alcohol-based bondings, they can be applied on both. Water-based only on dry surface, and acetone-based on moist surface. Okay, why is the solvent so important? The solvent helps the monomers to displace the water in the dentin and get the monomers inside of the dentin. Okay, once they're inside, we take away the solvent. How? Well, with air. So the solvent is evaporated, and then we only have our adhesive that we light cure. Well, self-etching adhesives, well, they eliminate the problem of incomplete infiltration. Well, self-etching primers, or they etch and penetrate in the same time, okay? So, etch and infiltrate in one step. What does that mean? Well, while they get into the dentin, they are etching the dentin and getting the monomers right away there. There is no possibility of nano leakage. Okay? Not possible. Good. Now, a very important thing. Shrinkage and shrinkage stress. Okay? Well, shrinkage is loss of volume, so densification of something. Every composite material and every adhesive shrink when they are polymerized, okay? Because the polymerization makes that the monomers that are not together, they come together. And this coming together millions of times makes the whole volume to shrink. Good. Now, 60 to 80% of the shrinkage can be controlled by the layering technique. So these are publications that calculate exactly how much a percentage is saved in shrinkage when we layer. So that's why we layer not only in the front because it looks good, we layer because we reduce the shrinkage, and with that we also reduce the shrinkage stress by modifying the C factor. Difficult, but who understands the C factor knows what I'm talking about. Okay, good. So for everybody else, we control the stress, the force of the shrinkage, and we control the shrinkage itself by layering. So we not only layer in the front, we also layer in the back. In the back, we layer differently in interproximal than in the center of the cavity. Okay, interproximal, if, for example, here, that's an interproximal view, okay, of a tooth in between the teeth. So we are actually the adjacent tooth and we look at this tooth right now, okay? And we are making the wall that will touch us, the adjacent tooth, okay? Then we do here, the number one is the dentin adhesive, okay? And then a flowable composite as a liner. That reduces the stress a lot, okay? And then we do 3 incremental layers so that we get to a good final occlusal and contact area. So how do we do the acid etching? We acid etch on enamel, and then we wait 25 seconds. Then we acid etch the rest, also on dentin, and we wait another 5 seconds. That means we have acid etched the dentin 5 seconds and the enamel 25 plus 5, it's 30 seconds. Then we put the adhesive. We make a very, very, very fine layer of flow, but not only in the lower part, everywhere on the walls also, okay? It's like a liner. Then we in a not very profound cavity, we can proceed nearly the same way as we proceed in the interdental area. But if the cavity is more profound, then we do 1 horizontal layer, then here in the cusps, number 3 that does not touch each other and does not go all the way up, okay, they shrink in this direction, and then we do number 4 light cure, and number 5, light cure. So adhesive, light curing. Flowable liner, light curing. Number 2, light curing. Number 3s, several 3s. In a molar, it would be 4 3s. Here we only see two cusps, but in reality there are 4 cusps, so 4 number 3s. And then we do 4, 5, 6, and 7. Okay. And after the number 3s, we light cure all the 3s at once. Then number 4, light curing. Number 5, light curing. Number 6, light curing. Number 7, light curing. Good. What possible errors in the adhesion technique can be done? Well, first of all, the diagnostic and radiodiagnostic, and also indications. So sometimes it's not for a composite filling or for a filling, it's for a crown. Okay, and we do fillings and we fail. No, that's because we did not do a good diagnostic and good diagnostic and a good indication. Okay, then traumatic preparation, not enough water spray, or second, old burrs that heat up too much the tooth. Then depth of preparation. The deeper we get, the more we can fail, because the tooth, we kill the tooth. Then correct isolation. Do we use a rubber dam or not? Sometimes we don't. Then acid application technique. Okay, is it the correct one, or do we just use 15 seconds for everything? Okay, then the drying technique. Do we dry enough, or do we let it moist for our adhesive system? Then do we use the correct adhesive system for that moisture of this surface of the tooth? Then the technique and time of application of the adhesive. Then the technique and time of evaporation of the adhesive. Then the composite, do we use a liner, a flowable liner or not? Then application technique, do we layer or no? Then the curing lamp is also helping a lot if we, with ramp start or soft start, helps to reduce the shrinkage stress. And the technique and time of polymerization, and then professional care and hygiene. Okay, the postoperative sensitivity depends on, first, the working technique of the dentist. Second, the working technique of the dentist. Third, the working technique of the dentist. Fourth, the working technique of the dentist. And then the material he uses. Okay, good. Let's go and dive into the how we have to bevel and how to we have to do several things to get invisible or predictable aesthetics in front fillings. For example, this wave bevel is not so easily detectable by the eye of the person that looks. That's why we choose always to have waves, or let's say not waves, irregularities. Straight lines can be seen very good. Irregular things cannot be followed so easily. Okay, so let us assume we have a tooth that broke. Okay, yeah, it broke here, so this is missing. Okay, here, this is missing here, yeah. And we want to make the bevel in the front tooth. We do double beveling. So the first bevel would be here, going from here to here. So this line here, this point is this here. Okay, can you see that? Okay, here. Okay, and it has to go down like a ramp of a parking lot. Okay, where you go up this ramp. That's a ramp. Okay, good. Why? Because we have to layer over it. So we have to make several layers so that this line here, this line cannot be seen. Yeah, but now we have this line. Yeah, okay. Now we need to make this line invisible too. How do we do that? With the second bevel. So that's the first bevel now. It's now beveled here. So this line is here, and this line is now deeper here. Okay? Now, how do we make this line? We will cover with dentin shade and then enamel shade. So we make it invisible. But now we have this line here. How do we make that disappear? Well, we double bevel. The next bevel will be to make irregularities there. How do we do these? Well, we do that with a rugby-shaped burr. Okay, we go there, and of course these irregularities have to be outside this line so that at the end it looks like irregular. Okay, so through the irregularities we make, and you see that here. Okay, this point here is this point here. Okay, this point here is here, but now a little bit deeper, and here is this point. Okay, good. First bevel and the second bevel. Good. So now we have to start from the back to the front to make it, to layer it. Okay. Now, if we have a broken tooth, it's difficult to, we can either use our thumb as the back wall, or we can make the back wall by ourselves. How? We make a mock up here. We make a putty, and then we make the line where the incisal edge is. Okay, where is the incisal edge? On the neighbor tooth. Okay, and then we cut the neighbor tooth and this tooth. So this is this tooth, and this is the neighbor tooth. Okay, let's go back. This tooth and the neighbor tooth. Okay, now we have here the neighbor tooth, and then we just paint on the putty where we want to have the incisal edge, following exactly the edge of the neighbor tooth. Then we take a burr, so we then paint the whole thing that we have to take away. Then we take a burr and we take that away so that it is on the same level as the other tooth or the rest of the tooth. Okay, and then we can start making the layers from the back to the front. Okay, good. How do we do the layers from the back to the front? Well, it depends on what material do we have. Okay, if we have a good material, we can do only 3 layers, which is the enamel on the back, then dentin in the middle, and then enamel in the front. Usually that is enough. So more sophisticated should be enamel and then transparent composite on the back, then dentin, and then in the front we have enamel. Now, if this constellation does not give us enough translucency in the incisal edge, we can use enamel and transparent on the back, dentin, and then or all transparent, dentin, and then enamel here, or enamel and transparent, dentin, enamel and transparent, to give the incisal edge much more translucency. Now, if we don't see the halo effect, that means this whitish line at the incisal edge, we can paint that, or we can do that with a bleaching or whitening composite. It can be flowable composite, can be a normal whitening composite at the really at the incisal edge, but from the back, and then dentin, enamel, and transparent. Okay, and then we have a nice halo effect. Good. The halo effect here, you see these whitish areas. Okay, good. We can also paint it with bleaching color. Good. Then, how do we give the composite a nice anatomy in the front? Well, the anatomy in the front teeth is divided in 4 different steps. Okay, the first step is the overall anatomy. So how does it look? Is it more squarey? Is it more long? How does it look? Okay, we always look at the others, at the other teeth, and we try to imitate our filling with that. Usually when we have like a class 4 filling to do, we fill up all the tooth, and then from there we just polish away and we make the anatomy. Okay, we design the anatomy. Then here the second step is the main shape, primary anatomy. So shadow area, reflective area in the center, and then again shadow area where it goes into the contact point again. Here, by making these lines more together, we can visually make a more narrow tooth, although it touches the other teeth. So we have a determined space because it has to touch the other teeth, but we can make it look smaller, although it touches the other teeth and has contact points, by moving these lines here. Okay, then we have the secondary anatomy, which is the vertical and the horizontal macro texture. And then we have the tertiary anatomy, which is the surface micro texture. Okay, very fast. Primary anatomy, I already said it. Okay, these lines, okay, they divide the shadow area from the reflective area into the shadow area again. Then inside of the primary anatomy, we have these angle lines. We have these embrasures, okay, that we also have in the primary anatomy. So we have to just copy the other teeth with that. And then we have the 3 planes here. 1 plane in the cervical area, 1 plane in the middle of the tooth, and 1 plane in the incisal edge. So it's not straight, the tooth, okay? So that we call that the buccal contour, okay? How do we do that? We do these lines by drawing a pencil. You draw with a pencil on the composite, and then you take away distal and mesial of these lines so that the lines stay there. Alternatively, you can use discs to do that, okay? You just put these lines in pencil and then you just polish away. Good. The second thing is you with a burr, you give the contour, okay, the 3 planes, and then with a polishing disc, you do these embrasures. Okay, and then once you have done that, you polish over everything again with a polisher. Then you go to the secondary anatomy, which is this vertical and horizontal macro texture. Vertical, well, the V shapes, okay? What do? You paint on the teeth. You divide it in 3 sections, and you paint on the teeth how these V's will be, one of them is longer and one of them is shorter. Which one? Depends on the literature you look. Sometimes they say the mesial one is shorter and the distal one is longer, and sometimes they say the other way around. Then we draw with a pencil, and then we use the fine grain drill to make these grooves. Okay. Then we use here to make 2 to 3 small grooves horizontally. We use a ball, a sphere. Okay. Then after that, we polish with this here over everything, over the vertical depressions and the horizontal depressions. Then for the tertiary anatomy, we make very fine lines all over the place, but only if the patient has this fine anatomy on his teeth or in all his teeth. If he doesn't have that, we don't do the tertiary anatomy. Okay, but usually we do that with very fine burrs, and then we polish over it. We do not press, otherwise these fine strokes would disappear. Okay, and then we polish over that with some polishing brushes and polishing pastes. Good. Let's go to the end of this lecture and some veneers knowledge that I want to share with you. Okay, very important to understand. Again, can we bond to dentin or to recession areas? Of course, because that is dentin. Okay, so good. Here's the thing. There are different protocols, and I will not go into details right now, but different protocols. If we use a self-curing cement, or if we will use a light curing cement. Okay, here are the different protocols. We try to do as much as we can on the veneer first before we go to the tooth. Okay, and then we place the veneers on the teeth, remove the excesses, and we light cure. Okay. In the dual curing cement, we cannot do so much on the veneer. We can only do the siling. If we put the adhesive already on the veneer in a dual curing cement, which uses a dual curing adhesive, then it would start to set already. And we don't know how long we will be at the tooth. So that we want it to set as soon as we are done with the tooth. This is possible with light curing because we cover the veneers against the light. So no light is going there. So we can put adhesive and we can put the cement already in the veneers and then cover them. Okay, but not in the dual curing cement because that would already start to set. So we go to the tooth, we do the steps on the tooth, and we do the adhesive, the dual curing adhesive on both, on the veneer and on the tooth, dry it, and then we charge the dual curing cement on the veneer, and then we place it on the veneers on the teeth, remove the excesses, and then we light cure. Okay, good. Then, also very important, it depends on the material that you use for your veneers. There are glass face materials like lithium disilicate, like feldspatic ceramics, okay, and they are pre-treated differently. They are pre-treated with hydrofluoric acid and with acylane. But if we use zirconium oxide veneers, because zirconium oxide is not a glass face ceramic, it is a metal, we have an acid would not do nothing to the zirconium. So we have to air blast this zirconium oxide first, and then use a different kind of silane, which is a GDP. Good. Preparation concepts. Not all the patients can be treated with no prep veneers. If teeth are going over one tooth over another, so they are mounted, then we have to take something away so that we can put a veneer on one tooth and a veneer on the other tooth. Otherwise, it would still be mounted. Okay, so we need to see the situation, and no prep veneers are good for small teeth that you want to make bigger and for minor diastemas. For example, peg laterals that you want to make bigger or minor diastemas that you want to close. Then you can make a no prep veneer. Okay, but all the other veneer situations require some enamel contouring. That means you have to take a burr and you have to take away enamel. Okay, you don't necessarily need to make a margin. Okay, but you have to take away enamel. So no prep is in reality, in most of the cases, low prep. Good. And we have to take into consideration that the veneer then is on top of the tooth. That means there is a margin near the gingiva and a step near the gingiva, and everything will be stuck here. So we have to take that away. How? With a very fine burr. We go inside of the gum from mesial to distal, mesial again, distal again, distal again, until all this step is gone in no prep veneers, okay? And then we go over it with a 30 fluted burr to make it very smooth.